Welcome back to the Am I Mental podcast, the Doctors in Court edition. And yes, I am back for another episode. And today I'm going to unpack another real medical case that ended up in court because it's about exploring the decisions, the fallout, and the lessons for you and for me and all healthcare professionals to learn today. I have a case for you that is quite tragic as it is instructive. It's the story of a post-surgical patient, his GP, and the devastating consequences of a missed legionella pneumonia diagnosis. It's a story about clinical judgment, vigilance, and the balance between intuition and evidence. And this case goes beyond the medical facts. It's about the human cost of errors and the impact on not only the patient, the family, and also the doctors who have to live with the decision. So let me dive right into what happened and why it happened so that we can learn from this. The patient in this case, and as always, you know it, if you've been listening to my podcast, you know that all these patients' names are all made up to protect privacy. And in some cases, I actually use real case names, but I will tell you if it's the real case. In this case, our patient, will call him Mr. David. He had a history of COPD and vascular issues. Now, he'd been under the care of his GP, who I'll call Dr. Cornelius. For some reason, I love using that name. So from now on, every GP in this podcast moving forward is going to be called Dr. Cornelius. Now, Dr. Cornelius was Mr. David's patient for many years, and he frequently complained of leg pain and difficulty walking. In August of 2006, Mr. David underwent a femocrural bypass surgery for arterial stenosis in his right leg. Initially, his recovery seemed uneventful. But just weeks after being discharged, things took a turn, and Mr. David became increasingly unwell with weakness, difficulty standing, and concerning respiratory symptoms. And on August 31st, 2006, his wife brought Mr. David to the GP, to Dr. Cornelius, desperate for answers. Dr. Cornelius examined Mr. David. He auscultated his lungs, and he found no signs of pneumonia. But, and this is interesting, he did conclude that Mr. David likely had a viral infection and ended up prescribing antibiotics as a precaution. But his wife, so Mr. David's wife, wasn't really convinced. She felt that her husband's condition was far worse, far serious, and trusting her own instincts, she took him to the hospital later that same day to the emergency department. At the hospital, Mr. David was admitted with severe pneumonia. Over the next few days, his condition deteriorated into respiratory failure and sepsis. He was later moved to the intensive care unit and even placed on mechanical ventilation. Further tests revealed a legionella infection, likely contracted during his earlier hospital stay. Legionella pneumonia is a particularly severe form of pneumonia caused by Legionella bacteria, and it's not your typical respiratory infection. It often hides behind non-specific symptoms, making it hard to diagnose without imaging or specific tests. Now, although Mr. David was eventually stabilized and discharged in late September, the infection left lasting damage. And over the following year, his health declined due to ongoing heart and vascular issues, and tragically, he passed away in November 2007. Following her husband's death, Mr. David's wife filed a formal complaint against Dr. Cornelius. She argued that he failed to recognize the severity of her husband's condition during the August 31st consultation. And according to her, Dr. Cornelius dismissed her concerns, focusing on mild symptoms and ignoring clear signs of post-surgical decline. She also argued that Dr. Cornelius' handling of Mr. David's chronic leg pain over the years had been negligent. She claimed he had repeatedly dismissed her husband's complaints without proper investigation or referral to a specialist. It wasn't until the bypass surgery that they learned the extent of his vascular disease. Dr. Cornelius, in his defense, admitted he should have referred Mr. David to the hospital on August 31st. However, he maintained that his clinical findings at the time didn't justify an emergency referral. He auscultated the lungs and found no signs of severe infections. The court's decision highlighted two key issues: the August 31st consultation and the management of Mr. David's chronic leg pain over the years. On the first point, the court found that Dr. Cornelius failed to meet the standard of care. They noted that post-surgical patients with sudden, unexplained declines require immediate referral regardless of the physical findings. The court acknowledged that diagnosing pneumonia, especially legionella, can be challenging. However, they emphasized the importance of a GP's not quite right feeling. Mrs. Davids had clearly communicated that her husband was deteriorating rapidly, and in such cases, caution demands erring on the side of referral. On the second issue, the court criticized Dr. Cornelius for failing to investigate Mr. David's chronic complaints properly. Over more than a decade, Mr. David had reported significant leg pain and difficulty walking. The court found that Dr. Cornelius relied too heavily on symptomatic treatments, like prescribing inhalers, without exploring underlying causes or referring to a vascular specialist. Ultimately, the court issued a formal reprimand, emphasizing that GPs must maintain a high level of vigilance, particularly with complex patients like Mr. David. While they did not directly blame Dr. Cornelius for Mr. David's death, they highlighted systematic shortcomings in his care. This case underscores how challenging it can be to diagnose pneumonia, especially in post-surgical patients. Legionella pneumonia is particularly elusive. It often presents with vague symptoms like fatigue and mild fever before escalating rapidly. A study published in Clinical Infectious Diseases 2020 found that 20% of Legionella cases are initially misdiagnosed due to their atypical presentation, and the authors recommended early imaging and urine antigen tests for high-risk patients like those recovering from surgery or with chronic illnesses. Another critical aspect is the management of chronic complaints. A systematic review in the Journal of General Practice 2019 emphasized the importance of investigating recurring symptoms. For patients with leg pain and difficulty walking, early referral to a vascular specialist can prevent severe complications. Ethically, this case highlights the need to listen to patients and their families. The wife of Mr. David was very concerned, and all her concerns were dismissed by Dr. Cornelius, even though she provided key observations about her husband's decline. And research shows that family input can be crucial in identifying subtle changes in post-surgical patients. I'm going to leave you with some thought-provoking questions. How do you balance intuition with clinical evidence? And should a GP refer a patient based on gut feeling, even if physical findings don't support it? Let me tell you something. I've been a medical doctor for over 18 years, nearly 20. And I have to say that the older I get, the more I rely on my gut feeling. And very recently, I did the same thing. I'd seen a patient twice, once at the clinic and once at home. The first time I saw the clinic, she came in with her neighbor. This lady is over 70, she's nearly 80 years old, and the only care or only people around her that she has are neighbors. No family, no friends, no children, nothing. Her neighbor came with her, and I was so happy to see her neighbor. And I even said to her, "Thank you so much, but this is not your concern." But I felt amazed. I felt really happy that she came. When I spoke to her, I highlighted the fact that I felt that she was a vulnerable patient. And I said to her, the reason why I say this is not only because of her age, but because she lives alone and she only has her neighbor to rely on. And that for me is already a kind of gut feeling, this is not good. I sent her home with some advice, and I said I was going to refer her to my nurse practitioner who was going to come home and visit her in her house to assess whether or not it was safe for her to be there. Let me say that she showed me quite a lot of resistance. And a few months later, I was called to visit her at home. And when I came home, she had fallen and her neighbor was there with her. And I said, well, I'm glad to see the neighbor again, but you must understand why I'm concerned about you, because now you've fallen and you didn't have anybody to call for help. What if you fall one day and you can't get up and your neighbor is not available? I really, really want us to put in place some form of care for you so that if you fall, you can maybe hit an alarm and it will alert carers to come and take care of you. When I was home, she gave me even more resistance. She started telling me how she didn't like she started telling me how she didn't like the first meeting with me. She felt that I was being very short with her, and I just wanted to kind of get her out of the office. And I said, look, I'm sorry that you felt that way, but I hope she understood that I only have 15 minutes per patient, and I need to do a lot of thinking, and I have to solve a lot of problems in 15 minutes. And she came with quite a baggage of things, and I could feel a lot of resistance. So I told her that at the moment, I still feel that resistance, but all I'm trying to do is help her. So I said to her, based on what I see now, my gut feeling says that if something happens to you, I can't provide that care. And I really need you to accept the fact that you are getting old, you are elderly, you're vulnerable, and we need to get home care for you in place. And with a lot of resistance, she agreed to at least have a physiotherapist come to her. The next day, 2 days later, I was called by that same physiotherapist, and he said, it's not going well. She fell, she laid next to her bed for the whole night because she couldn't reach her neighbors. And my gut feeling said this lady needs to be hospitalized, not because I felt that she broke something, but because her care needed to be escalated so that she can get the care that she needed. And so, yes, sometimes as a GP, I base my findings on gut feeling and not on physical feelings. And I say that also to the patients, and I say that to the doctors that I refer patients to. I say, look, I'm sending her in because maybe she has a fracture of her hip, but if she doesn't have a fracture, please keep her in because my gut feeling says it's not safe for her to go home. The second question, how can GPs improve their approach to chronic complaints, ensuring they don't miss underlying conditions while managing a busy practice? Wow. My practice is busy. I have a practice of over 3,000 patients, and I deal with a lot of patients with chronic complaints. And the way that I approach these complaints is by telling every single patient that I cannot do this on my own. I have a team, and my goal is to make sure that the team feels involved in every single patient, because I feel that individually as a team also, but individually, we each have a role for each patient. So, for example, if I see a patient that is complex, I involve a nurse practitioner who takes care of, let's say, the comorbidities like diabetes or COPD or high blood pressure. Now, it becomes complex for me when there are multiple comorbidities and there are also social problems. For example, the example of the patient that I just said who was living alone, relying on her neighbors to care for her. That becomes complex because once a patient is no longer safe to live alone at home and doesn't have the added care that she needs, it gets complex. So what I have to do is rely on other people's expertise and talent to make sure that we do the best we can for that patient. Chronic complaints and complex complaints don't mean they have to go together. But the moment a chronic complaint becomes complex, then you really need to rely on more than just yourself as a GP, especially because the GP practice will always be busy. Tell the patients that you do not do it on your own. Let them know that you can't do it alone and that they need to accept the fact that as a GP practice, you're going to have to rely on other expertise. That's how I handle it. Before I leave you with these thought-provoking questions, I want to talk a little bit more about atypical pneumonia and legionella. Atypical pneumonia, like legionella, differs from typical bacterial pneumonia. The symptoms often include fever, fatigue, and mild respiratory issues, but systemic signs like gastrointestinal symptoms, confusion are usually red flags, and diagnosis requires advanced tools like urine antigen test or PCR. The 2024 study by a very complicated name, which I'm not going to say right now, is basically Greek. I'll try. Georgakopoulou and colleagues in the experimental and therapeutical medicine found that legionella pneumonia is more severe with mortality rates up to 33% in hospitalized cases. It also emphasized that early targeted antibiotics like macrolides or fluoroquinolones significantly reduce complications. Their research highlights diagnostic challenges due to overlapping symptoms with other infections, and a weighted point system that considers epidemiological factors, extrapulmonary symptoms, and imaging findings can guide clinicians toward early diagnosis. So what are the take-home messages for health professionals when thinking about legionella pneumonia? Well, weighted diagnostic systems, as recommended by the authors, improve the accuracy of diagnosing atypical pathogens like legionella. This early referral saves lives. So when you doubt, especially in high-risk patients, refer. Just refer for imaging and refer for testing, refer to the pulmonary department, just refer. And you got to recognize red flags, especially when it comes to people who've been hospitalized in the recent past. Post-surgical patients that have systemic symptoms should trigger a high index of suspicion for nosocomial. Recognize red flags. Post-surgical patients with systemic symptoms should trigger a high index of suspicion for nosocomial infections like legionella. Another take-home message which is really important is advocate for care. If symptoms worsen rapidly or don't align with initial diagnosis, insist on further evaluation. Now, the wife of Dr. David's actions were critical to getting Dr. David. It wasn't the wife, oh my gosh, she wasn't. Another take-home message is how to recognize the signs. Symptoms like confusion, diarrhea, or worsening weakness may indicate something beyond a simple viral illness. Let's look a bit more about the data concerning legionella pneumonia. Legionella accounts for 7 to 15% of severe pneumonia cases globally, with mortality rates significantly higher in delayed diagnosis. And this increasing resistance to antibiotics, and that underscores the need for immediate use of effective drugs like fluoroquinolones and macrolides. In closing, this case is a stark reminder of the stakes in medical practice. While we strive to make the best decisions, sometimes listening to the patients and the families can make the biggest difference. And for patients, your voice matters. Advocating for your care isn't just your right, it can save lives. Thank you for joining me on the MI Mental podcast, Doctors in Court edition, and I really hope that you understand how important this is for me to do. And I do it with pleasure. And I would love to have some feedback and some comments and let me know what it is you're looking for. And, from a doctor's perspective, I feel that we must create an environment where everybody feels heard, where we acknowledge concerns, but I do also believe that it's all about teamwork. Families should advocate from a place of concern and observation, and doctors should provide the expertise and guidance needed to act on those concerns appropriately. Thank you for listening, and I'll see you next time on the next episode.